Wherever you are, most welcome to the ACS Accountability Learning Exchange webinar. We are very, very delighted to have you and really appreciate that you've created time to participate. Just checking that all of us can have a choice of language just before we start. Please, if you can go to the icon that's depicting a globe just next to share slides, and then you click on the language of choice. We are providing English and French for now, and we hope most of the participants can be able to use either of those two languages. So please go there and click so that you're in the right room. We have interpreters who are doing a very good job for us to ensure that all of us can participate. Good. So we are anticipating a very, very engaging and insightful session this afternoon. And so we very much look forward to your comments and questions. Please, we want you to provoke us. So, and talking of comments, please use the chat option that is below there. I know most of us are very well versed with that, to share your thoughts. And of course, the moderator of the day will ensure that as much as possible, we pick on your questions, on your comments, so that our speakers can respond to that. So please engage us, provoke us, share with us your thoughts of the discussions that are going to take place today. And in case you'd like to speak, that is also open. This is a targeted forum for all of us. So we would like also to hear your voice. So if you'd like to do that, please raise your hand using the raise hand icon. And if you want to get there, just in case you've not used it before, if you click the icon that is showing participants, you see a list of participants, and then below that there is an icon with a list. And so if you click that, then the moderator will see it, and we'll unmute you so that we can hear your voice. You can make your comments or your questions directly. So please do that at the appropriate time, and we'll appreciate it. You will have received a pre-event survey, most likely via your email. So if you can do that also, if you can fill it out as we continue with the discussion, we really, really appreciate. We want to ensure that this session and any other that you plan is definitely speaking to some of your ideas and is as effective. And we are efficient also in the delivery of this forum. So please, if you can do that, we'll appreciate. So now to kick off our discussion, I am very, very honored to turn it over now to my colleague, Shekina Tool. Shekina is the Deputy Technical Director of ACS and has been involved very, very closely with ACS for the last 3+ years, and most of the work that is going to be shared today. Lots of interesting and exciting conversation that's going to be shared by our panel. So Shekina will take a few minutes just to frame this learning event and then introduce our first speaker. So Shekina, if you are there, over to you now. And thank you.
Thank you very much, Dr. Kemafi. Ladies and gentlemen, dear participants, welcome again to this learning session. Today's our webinar has 3 main portions. Next slide, please. Okay, so I'm delighted to introduce the ACS project and its works on accountability so far. In the second part, we will share findings from the different conceptualization works and studies. And my colleagues, Christelle, a researcher at CERUD in Benin, one of the ACS implementing partners, Conrad, the ACS Benin team lead, and Matsae, our project coordinator in Botswana, will be presenting that portion. And finally, we will open the floor for deep discussion that will be facilitated by Alison Kelly, the ACS project director. Next slide, please. So ACS is USAID-funded learning project that supports Sub-Saharan African countries to navigate the complex UHC processes by conducting systematic stakeholders' needs and demands assessment to better position our assistance. So we facilitate multi-sectoral collaboration to tackle issues that are identified by country stakeholders. We provide health financing technical support as an entry point to UHC. And we also promote learnings from countries' own processes, and we organize knowledge sharing among them. And we finally support ACS UHC stakeholders to improve accountability mechanisms. Next slide. At ACS, we approach accountability through a couple of support areas. First of all, we are laying down the foundations for a regional collaborative on accountability. In addition to that, ACS supports accountability intervention in countries like in Burkina Faso. We will talk more later. In our implementing countries, we have staff who facilitates policy dialogues. We try to incorporate accountability activities and to create cross-country learning opportunities as well. Our ambition is for sure to strengthen capacities in accountability matters. So we've started that by, a conceptual clarification. As you might agree with us, accountability being an elusive concept, for us, it was really important to clarify or try to clarify how accountability functions in a UHC ecosystem. And this is why we spend significant time to understand the how. Crystal is going to tell us more about the Heaven and Health framework. It's worthwhile also to mention that in 2019, a group of practitioners gathered in Nairobi and reflected on avenues to take our accountability effort forward. And they agreed that there was a need to study and figure out the accountability status. And this is where the accountability mapping is coming from. Next slide. Today, we will present the findings, as I mentioned earlier, of this mapping exercise, but I would like to share the underlying objective here. They are three. First of all, we wanted to identify accountability key players, networks, movements that are involved in its promotion. We also wanted to understand what processes, approaches, platforms are used in those accountability intervention. And finally, our hope is to determine enabling factors and obstacles to promoting accountability across Sub-Saharan African countries. Next slide. These are the main research questions that we brought in mind when conducting this mapping. I'm not going to read all of them, but in a nutshell, who were the major players? How were accountability initiatives organized? What strategies, structures, policies, institutional arrangements were in place? More important, what were the capacity gaps? Next. Now, allow me to zoom out a bit the concept of accountability and bringing into perspective in the ACS context. We have a threefold take regarding the accountability, the project accountability function. We see it as a process made of activities that we consider as mutually reinforcing. First, it's important to deepen our understanding of the concept, and we will continue to invest on that to continue strengthen the conceptual clarification through the Heaven and Hell framework. And then we apply that in the development and implementation of in-countries accountability intervention. In Burkina, for example, we are supporting the creation of a social movement for UHC with a well-respected NGO network called RAME. And then we will learn from implementation findings and will infuse those learning to refine the conceptual framework as we go. Next. Today, we want to establish a communication channel with you guys and receive your feedback, your reflection, your criticism. That will allow us, further improvement of tools and approaches we use and we support. We are also eager to explore with you opportunities to disseminate and use ACS learning. And more importantly, I think one of our big collective achievement would be the identification of collaboration opportunities that are linked to the assistance you provide to your respective supported countries. And now I'm going to hand over to Crystal, who will present the Heaven and Health framework and share some exciting findings on conducive policies, processes that promote accountability across the continent. Crystal, floor is yours.
Thank you very much, Jekna. Hi, ladies and gentlemen, and thank you for joining this webinar. What is accountability? There is no broadly accepted definition for this concept, but for any accountability relationship, we should have two actors, one called the agent and the second called the principal. So accountability could be defined as the obligation of the agent to inform about past and future actions and justify these actions to the principal. The principal have the obligation to provide resources to the agents. He has also the power to reward the agent in case of good conduct and to punish him if he misconducts. Slide, please. There are many classifications of accountability. We can propose three types that we can apply to the health system: financial, performance, and political accountability. Financial accountability relates to control the use or misuse of financial resources. Performance accountability control if resources are used according to legal frameworks to obtain results. The difference between financial and performance accountability is that performance accountability focuses on results, while financial accountability insists on procedures. Political accountability involves respect of electoral promises. These three types of accountability are aligned with key dimensions of UHC, financing, health service delivery, and political processes necessary to design and implement any UHC policy. Slide, please. ACS proposed a framework to understand the way accountability affects countries' dynamic toward UHC. Key dimensions of this framework are accountability actors, type of accountability between the different actors, hard and soft components that produce accountability, conditions of a culture of accountability, and how accountability is generated. Slide. Our framework, our Heaven and Health framework, is built on a triangular relationship between three key actors of the health system. We call them the 3P, the policymakers, the providers, and people. Policymakers could be technical or political policymakers. Provider could come from private or public sector, and people could be service users, general public, and also organized civil society. Between policymakers and providers, we have performance accountability. Between providers and people, we have financial and performance accountability. And between policymakers and people, we have the three types of accountability defined by Breaking-Off. Slide, please. There are four components that we call, some are hard, some are soft, that work together in any accountability relationships to produce these concepts. The first one is health system architecture that relates to which organizations incarnate relationships between actors. The second one is law and rules that can be formal and informal that structure the accountability relationships. Voice and participation are the third one and are about the different stakeholders that influence the accountability relationships, the power of each actors and their interest. And the last one is information and intelligence that are related to the source of information and evidence available to assess accountability relationship. Slide, please. And those four components, I said that they work together to produce accountability, but they work under key conditions that Bregman proposed to us and we adopt for this framework. The first condition is clear expectation about the outcome. So the principal should clarify the expectations to the agent. The second one, the second condition is the agent should have the clear capability to achieve the outcome. The third one is the measurement tool, the measurement of the result that should be available for this for any accountability relationship. And the fourth one is clear feedback processes that will be clearly defined between the principal and the agent. And the last one that is very, very important is clear consequences. So it should, that we clarify what will happen if good conduct and what will happen if bad conduct. And also the principal should have the capability to enforce the sanctions. Slide, please. So we talk about the three key actors of the health system, the 3P. We also talk about the type of accountability between each binary relationship between policymakers, providers, and so on. And I also present the hard and soft components that work together to produce accountability. These components are represented on this figure by the wheels on the between policymakers and providers. For example, you can see we wrote it inside the wheels. And we also present the 5 conditions of a culture of accountability that are at the center of this framework. So the question is, how accountability is generated? Accountability is generated if the 4 components works well under the 5 conditions. And if, for example, we have good performance accountability between policymakers and providers, providers will give good quality of care. And if the quality of care is good, the people will use the health service. And if health services are well used, people will trust more in the health system. They will contribute more easily to the pooling of resources by giving, for example, the premium. And if you have more resources, policy makers will invest more in the health system, and this will improve the quality of care, and the cycle will come again. The people will use more the health service, and so on and so on. This will create a positive vortex that will bring a country toward UHC, and we call this scenario the heaven scenario. Slide, please. The opposite is the health scenario, and you can guess that we have bad performance accountability relationship between providers and policymakers, and bad quality of service, and so on and so on. That will bring a country away from UHC. Slide. ACS performed a literature review to identify evidence-based interventions to improve performance accountability between policymakers and providers. We use the Haven Health framework to assess those interventions. I will not present all, but I will take the example of accreditation, for example. You see, accreditation, if you see the 4 components that will work together to produce accountability, accreditation respects 3 of them: health system architecture, laws and rules, and information and intelligence. And accreditation respects the 5 conditions for a culture of accountability. So that is the way that this framework can use, and have any other way that I will share in the take-home message. Slide, please. So the Haven and Health framework can help to assess where a country stands and identify if they are in accelerating scenario, what we call the Haven scenario, or a decelerating scenario, what we call the health scenario. It can also help to identify the relevant issues to be addressed. So what is it the condition that is not good? Is it the component that are not implementing and does not function well, and so on? It also helps to analyze if the funded solution could help and how they could help to improve country health system. And to successfully implement accountability intervention, it is important to adapt the interventions to country priority, to involve key local stakeholders in the design, implementation, and also evaluation of this intervention. And it's important to design multifaceted intervention for concrete and sustaining impact on health system. Thank you very much for your attention.
Okay, thank you very much, Christelle, for that. Now let's listen to the accountability mapping findings. I should mention that these mapping studies took place in Benin and Botswana. We are preparing to conduct the same exercise in Togo. Today, we present the findings of the first round, and we also intend to perform cross-country analysis once we completed the country studies. Just to mention that the Benin study involved 35 key informants across all levels of the health system, nearly 100 youth. In Botswana, we talked to 37 key actors. And now I'm going to turn over to Conrad to share key lessons learned in Benin. Conrad, floor is yours.
Thank you, Shekna. Hi, everyone. In Benin, the accountability mapping exercise provides us this first opportunity to scan the accountability environment within the health system with an innovative tool and an external and experienced perspective. May I quickly summarize the context of Benin in which we are experiencing a new health insurance scheme under the Revealing Benin program, a roadmap for the government action to transform the social and economic condition in Benin. Indeed, our findings are mainly influenced by this environment imposed by the strong leadership of the president. In terms of accountability actors, we did classify them in the groups of policymakers, implementers, either from private or public sector, academics, and civil society organizations. When it comes to policymakers, we found out that most of the time, accountability policy documents are available. However, a very little emphasis is put on how to ensure accountability. Therefore, there are no clear sanctions for misuse or abuse of public resources. And I remember this member of parliament who quoted, "The parliament will need to focus now on the modalities of application of accountability laws instead of voting new laws." In the same way, in the public sector also, although accountability tools are available, there is a little capacity to use them, and implementers are more concerned by vertical accountability to supervisors than transparency to the community. Moreover, private sector implementers and academics are not most of the time included in policy formulation and implementation. Finally, community society organizations, when they are associated, are not valued and are not allowed to play their role as representing citizen interests to duty bearers. Slide, please. Regarding accountability tools, many of them have been identified in Benin. The toll-free call service is set by the Ministry of Health to get the feedback from users to improve health service delivery. Unfortunately, with a very low uptake because most of the time there is no feedback to the complaint. Community radios are utilized for health education, creating awareness on health priorities and emerging diseases, as well as for issue resolution due to the anonymity provided by radio to avoid retortion from health providers. Suggestion boxes are located within the health facility for clients to express sensitive and anonymous complaints. And during the study, it was noted that their effectiveness remained very low, especially because of the low literacy and the cultural respect to health providers. Indeed, it is culturally unacceptable to denounce a healthcare provider who is considered as a lifesaver. Slide, please. However, some technical working groups are available under the leadership of the Ministry of Health at the national levels. CSOs and private sectors representatives have not been involved in the design and implementation of important programs such as the health insurance program. And finally, we identify the existence of health committees at all levels of the health system, which are assigned to multi-sectoral review, information sharing, program coordination. And also, unfortunately, with a very low experience of community representative on decision-making. Here again, as quoted by a public health officer, when the community representative do not find the benefit they are expecting, they start to withdraw. Slide, please. In summary, we identify many gaps after the accountability mapping exercise. There are in terms of awareness on the role of social accountability in improving health outcomes, organization capacity of the civil society, adaptation of available accountability tools to social context, and inclusivity in stakeholders' engagement in the dialogue platforms. Slides. To conclude, I would say there is an opportunity in Benin to leverage on the political commitment to create space for accountability in the health system. According to the findings of the mapping exercise, we can say that policy documents exist but are not implemented or not disclosed enough. Institutions exist but are weak or unaware of the role they must play. And finally, tools exist with a poor optic. Thank you.
Thank you, Conrad. Now, let's turn over to Masai. Masai, floor is yours.
I'm sorry, I didn't unmute. Good afternoon, everybody, and thank you, Chekna. I'm going to share the learnings from the Botswana mapping exercise and start by just saying that in Botswana, the identified actors in the space of UHC accountability includes policymakers, service providers, people or the citizenry, civil society organizations, and the media. Policymakers oversee development of policies and legal frameworks for accountability, which is actualized through regulatory and oversight structures, including, for example, the Public Accounts Committee. And that is basically a structure through which financial accountability is actualized. And the policymakers are responsible for generating policy in favor of UHC, and they're also responsible for making sure that the health system is arranged and organized in an optimal manner to ensure that health outcomes are realized. However, when it comes to the health landscape, we do have a challenge in that the Ministry of Health and Wellness has responsibility for HIV service delivery as well as coordination of services. And we find that we also have a National AIDS and Health Promotion Agency, which is also charged with the responsibility of coordinating HIV and AIDS services. In this way, we are finding that functions are duplicated, there's competition for resources, and this results in confusion amongst AIDS stakeholders, including development partners. The findings of the exercise revealed that when it comes to health service providers, poor monitoring and evaluation systems were identified as the biggest negative. They are there, but they are not strong enough to inform decision-making and to also assist in adequate and comprehensive reporting to funders, including the government. There's also inadequacy in the area of health research, leading to poor evidence-based allocation of financial resources. Healthcare providers have responsibility for allocating resources that have been provided for health and prioritizing programs and services. The minister in the Office of the Presidency did say that monitoring and evaluation is an essential public service management tool meant to strengthen performance. He said it was government's responsibility to improve productivity and ensure that projects were undertaken and completed on time. And this is in the realization that the M&E systems that are weak are negatively affecting performance and completion of services on time. The next stakeholder there is the citizenry or people. People are generally consulted through public hearings, and the observation is that even though they are consulted, there is basically just a sense of consultation because the structures for consulting communities are poorly organized and do not provide for meaningful participation in any way, especially in budgeting processes and in the generation of legal instruments and policies. Next. Slide. Civil society organizations are organized into networks and coalitions for collective bargaining, and they are generally responsible for providing some services to disenfranchised members of the community, including key populations, and they unfortunately have to rely on government and on donor funding for their functions. This has been highlighted as a negative because it affects their ability to be independent in thought and to also make decisions in favor of UHC, which are not necessarily influenced by the donors or by government. The last one there is the media. And when it comes to the media, which is supposed to act as a bridge between and the people by relaying information and creating awareness over incidents that threaten to violate the right to health, we have a difficulty in that there's weak sensitization of media practitioners on health strategies and priorities with centralized control over messages or releases of information going to the media. We realized or we experienced an improvement with the COVID-19 response where there was greater transparency and release of information was a little freer, and there was also increase in the utilization of technology. Next. Next. Slide. Okay. A number of approaches and tools are basically in place to promote accountability for UHC. And under legal and policy instruments, a number of tools, including structures that both at national and subnational level have been established to provide guidance and oversee compliance with set processes and protocols, which basically have to do with looking at financial compliance and perhaps also looking at performance. For example, we have laws that protect whistleblowers, and we also have laws that are supposed to promote transparency and information disclosure. We also have oversight and M&E structures and systems. And these are basically key and important because they provide for effective measurement tools as we track performance and also account to the citizenry. We have financial audits. We also have multi-stakeholder structures that oversee the implementation and also oversee reporting back to communities and to other stakeholders. We have a participatory budgeting system, which is nevertheless not as strong as it should be, and is a system that should be looking after issues of ensuring that there's value for money and there's equitable distribution of resources, not just money. When it comes to citizen participation, the use of traditional platforms, especially tribal gatherings under the leadership of different Dukosi or Bukosi, which is basically our chiefs, is an important means of mobilizing communities around the health agenda. And we have seen this being a platform that is used by both politicians and service providers. Of note is the liaison function of traditional Dukosi or chiefs with traditional healers for collaboration with the health sector in reduction of harmful practices. They actively mobilize communities for participation in the uptake of health services We experienced difficulties in the rollout of our safe male circumcision program, and it was with the intervention of the chiefs that we were able to see men take up the program and participate. Public information sharing is through toll-free numbers, which are in all hospitals and also at the ministry headquarters. We also have radios and TV for public service announcement and education or public education. The use of social media has significantly improved, of course, with COVID-19. There is a significant use of Facebook by the government, Twitter, and as well as SMSs. Next. Slide. Okay. Of course, there are some capacity gaps, and of note is the area of monitoring and evaluation. When it comes to civil society organizations, M&E systems were observed to be centralized and lacking presence at program level. Lack of data on program performance and financial performance are also rendering financial compliance a big concern, especially for development partners who fund CSOs. At the political level, the harmonization of policies remains weak, and there's need to look at perhaps streamlining where there are mandates that overlap. And of course, inclusive budgeting and planning processes, inclusiveness in planning and budgeting processes so that the voice of the different communities and constituents can be factored into those important processes. And then again, with providers, M&E systems, big monitoring and tracking. The implementation is difficult, where we find that we have weak M&E systems. We are not able to basically see how the outcomes that have been defined by the policy level are going to be realized. And there's also weak private sector engagement. In relation to the citizenry, is of course meaningful participation, meaningful engagement that has been a significant outcome. Next slide. Slide. Right. So what are the takeaways from the mapping exercise in Botswana? Botswana seems to have a fairly strong accountability mechanisms, mainly due to robust high-level financial oversight and strong government community engagement. These basically account for good political and financial accountability. Whereas when it comes to performance accountability, it is really significantly compromised by the weak monitoring and evaluation system. And the mapping exercise basically indicated that policymakers seemed to rate performance accountability not that bad, whereas those people who function at operational level have significant concerns around performance accountability. Civil society organizations and youth organizations are actively engaged through multi-stakeholder technical working groups, and they participate in the national discourse through well-established advocacy mechanisms. Though some civil society organizations strongly felt that really the lack of independence makes it difficult for them to fulfill their watchdog role. Thank you. Over to Chekna now, who is going to basically take us through the salient findings.
Thank you very much, Masai. At this stage, we really want to hear from you. So, but let me share quickly a few reflections over this learning shared by my colleagues. Through literature reviews, studies, what we observe is that there are different kinds of accountability intervention. Some work on the structural component, like laws and rules, and or voicing and or intelligence through formal processes, while others can contribute to enhance discrete dimension of accountability, even without setting up, justification platform, arbitration processes, or clear consequences after appreciation. So we think that it's important to situate yourself in this myriad of intervention when we think about accountability in health system. We've found out the critical ingredient of the culture of accountability that can help increase individual, organizational, and systemic performance, mostly in, let's say, less institutionalized setting. And what I mean by institution here is the set of rules, regulation that are commonly accepted and enforced. Talking about major conceptual gaps we've observed, when it's come to institutions, accountability from our perspective shouldn't be seen just like a mechanism, because it's built and sustained upon a set of value like transparency, responsibility, responsiveness, controllability, etc., and so and so. And the reality is that most often, intervention fail to integrate the different components of the culture of accountability to produce the intended effect. We've also noted a need for greater alignment with social norms. And that note, two examples struck me particularly. Complaint boxes, for example, fail because probably denunciation is not a value principle in Beninese culture. On the other hand, we assume Botswana Health Forum are successful because they are endorsed by and built on well-respected traditional authorities. We've also found that accountability actors use a lot of frightening vocabulary, like supervision, control, audit, sanctions, and don't present it as an opportunity to learn upon mistakes, upon errors, as an empowerment tool that rewards performers as well. And we believe that that unbalanced approach undermines accountability efforts. This is where we think, we believe that there are missed opportunities to activate the triad, inclusion, accountability, and collaborative learning. On the implementation side, good intents sometimes conflict with the actual practices. For example, in Benin, there is an appetite for stronger accountability that calls intrinsically for power shift, negotiation, while the government's management style is more inclined to imposition, to power concentration. So human factor weighing in a lot on accountability mechanism efficacy. Among the three actors, you may remember from the framework, policymaker, provider, people, there is little doubt that policymakers and providers don't usually create space for people inclusion in health issue resolution processes. So we need to be really intentional about the mitigation strategies in our accountability intervention to empower people on that respect. Now I turn over to Alison to facilitate the discussion on this finding. Thank you to listening to us.
Thank you, Shekna. And thank you to Christelle, Conrad, and Matsai for sharing this work. Thanks to all the participants for being part of this. I want to just clarify that this is our first time of presenting this body of work, which is, we think, exciting and touching on some new ground, but also one that we really want feedback on. We really want sort of constructive criticism and engagement. So we're looking forward to this part of the session almost more than the rest, hearing from you guys. I asked in the chat, I don't know how many of you have that open, to put the country in which you're working primarily or you're supporting primarily, because I think it would help us to get sort of a sense of who's in the room. And we have and you're welcome to ask questions or make comments either using the chat function or by raising your hand, whatever you feel most comfortable with. We'd love to hear voices as well, other than our own. But there's a first question from Simon Cabouret. Simon is the head of CSO in Burkina Faso. And he had a question about whether this work that we've been doing on ACS has made a direct link, especially the mapping studies, between these accountability mechanisms and explicitly monitoring UHC progress. So I would love to ask thoughts from the ACS team who's been working on this, whether you see direct links being made at your country level between the accountability mechanisms that are in place and being used and explicit monitoring of UHC. Conrad, do you want to start?
Yes, thank you, Addison. I think that primarily before we identify the accountability actors and tools, we consider that all the actions, all the initiatives in terms of health are contributing to universal health coverage, because in most of our countries there is no direct link between what they are doing for health daily and universal health coverage. So we consider that all these platforms with their functioning, with their role in the society, are contributing to UHC.
Thanks, Conrad. Matsai, any reflections there, or Jane, also from Botswana? You're on mute, Matsai, if you want to unmute.
Okay. I wasn't sure. Yeah, we are finding that actually there's a need to provide a linkage between universal health coverage and the work that is being done around health, so that people should understand that what they are doing is that they are actually contributing to the improvement of livelihoods and health outcomes, and in so doing, basically responding to the goal of universal health coverage. So each time there is an opportunity, we try to make sure that we bring in UHC, so that people should understand that basically the matters of quality and cost cannot really be removed from everyday service delivery conversations. And they should also talk about the ability of lack thereof when it comes to meeting the needs of those people who are disadvantaged, either because they are vulnerable or otherwise. But in terms of just really ensuring that, or structuring things such that universal health coverage is really addressed in a purposeful manner, where there is clear understanding and clear alignment that is basically right at the top of everybody's mind, that is not there. And we need to make sure that basically the performance of the healthcare or the health sector is really monitored, such that we are tracking how we are doing with the sustainable development goals, especially universal health coverage. And we are hoping that once our report has been finalized, it's a report that we will then basically bring to the attention of the ministry and try and see how then the areas that have been identified as areas for improvement are addressed.
So I think I'm hearing you say that this mapping is kind of a tool that can contribute to having a more explicit conversation about that with national stakeholders, and hopefully build a more explicit role for these mechanisms to track UHC. Simon, I know you want to come in here. Je sais que tu veux intervenir. I think that, so Simon would prefer to speak in French, and I think we should let him speak. I think that if everyone just who doesn't understand French clicks on the button for interpretation and picks English, you can get a direct translation. Simon, à toi. Simon?
Allô?
Oui, vas-y,
Oui,
on
allô?
t'écoute.
Oui. OK, merci Alison pour la parole. Et en fait, la question que j'avais posée, c'était vraiment, on a posé la question parce que c'est le même souci que nous essayons de combler ici. L'idée pour moi est qu'un système de redevabilité n'est efficace que si on a des paramètres de départ, des références sur lesquelles on peut rapporter les informations qu'on nous donne. Si, par exemple, un ministre ou un directeur me donne des informations sur la disponibilité en ressources ou bien sur les résultats obtenus à l'issue comment on appelle, de prestations de services et tout, je dois, pour apprécier, est-ce que c'est assez, les résultats sont bons, pas bons du tout ou carrément mauvais, il faut que j'ai des références. Sinon, je risque d'avoir des informations et je ne sais pas comment est-ce que je les exploite. La redevabilité a un sens quand je peux prendre des informations et les rapporter à quelque chose et pouvoir qualifier ces informations et interpeller alors maintenant celui qui m'a donné les informations. Mais si je n'ai pas ces références, je vais recevoir des informations, je ne peux pas les qualifier, donc je ne peux pas interpeller. Alors que celui qui donne des informations en étant sûr qu'on ne peut pas l'interpeller, il n'a aucune inquiétude à donner l'information. Et dans ce cas, il n'y a pas de redevabilité. C'est juste un système de communication des données, mais il n'y a pas de redevabilité parce que la personne qui reçoit n'a pas de référence pour apprécier, qualifier l'information et interpeller sur la base des références. C'est ça que je demandais. Est-ce qu'au niveau des pays, il y a des pays qui disposent déjà des référentiels, des références à atteindre en matière de CSU qui permet d'utiliser ces données pour pouvoir émettre des opinions sur les informations qu'on donne et interpeller.
Merci, Simon. I hope that that translation was made, but maybe just to quickly say that I think his main point is just that it's important to have sort of a clear reference point or reference indicators to level the playing field and make sure that information that is shared around accountability is shared and used in a structured way that everybody understands. And that's its power. And so he's wondering if in the countries where the studies were conducted, does that sort of reference exist? So I would love to hear from Benin on this. And Christelle, I don't know if you have some thoughts on this as well. Christelle or Conrad, and you're welcome to answer in French if you're more comfortable that way.
Thank you, Alison. This is Conrad. I would say that universal health coverage is multisectoral. For me, it's very tricky and difficult to have some referential to evaluate how actors or approaches are contributing to UHC. I would say, for instance, in Benin, our entry point for UHC is the health insurance scheme that we are experiencing with the main goal to lift out the poorest from the poverty. So this is not only a health issue, it's also social affairs, it's also Ministry of Finance, it's also Ministry of Law, it's also from the Parliament. So for me, it's very difficult to have indicators and to evaluate. At least in the end, we can know how many people were lifted out from the poverty. But in the meantime, we can take into account all the actions that are working together, all these initiatives, all the platforms that all the actors that are contributing to achieve this goal. And it is not only a matter of health insurance, it's also about fighting HIV/AIDS, fighting malaria. It's also about working for maternal health. So it's a whole, and we must consider all these actions to improve UHC. Thank you.
Would any of the other panelists like to add to that? Christelle? Shekna,
Yeah.
would you like to jump in?
Oui, je voulais intervenir ici pour la question de Simon. Je crois que Simon relève un point très, très important. Cela n'est pas venu des résultats des exercices effectués dans les pays spécifiquement, mais on a relevé ça dans la revue de littérature. Et cela rejoint les conditions que Christelle a élaborées tout à l'heure concernant les clear expectations, c'est-à-dire les attentes claires. Et ça, c'est un ingrédient très, très important de la culture des résultats. Quand on n'est pas clair sur les attentes, quand on n'est pas clair sur les résultats qui doivent être atteints, et je prolongerai même, définir clairement les attentes, les indicateurs, les niveaux qu'on veut atteindre, mais aussi se mettre d'accord sur les instruments pour pouvoir se fonder une opinion, les instruments de mesure, les méthodes. Ça, c'est vraiment important. Et pour boucler la chaîne, une fois qu'on aura fait ça, l'échelon supplémentaire, c'est quelles conséquences sont prévues pour encourager la redevabilité, pour pas que ça soit un exercice futile, juste pour, comment dire, fix the boss, juste faire le checking et dire oui, on a fait l'exercice. Il faut qu'il y ait des enjeux. Voilà ce que je voulais dire. Il faut qu'il y ait des enjeux. Ça ne peut pas être un exercice où on fait, où on ne fait pas, il n'y a aucune conséquence. Donc, je crois que ça, c'est un élément très, très important de mettre que ça, c'est des ingrédients très importants pour asseoir la culture de redevabilité.
Thanks, Shekna. And Simon is pleased with your answer. Christelle, I know you're trying to come in, but you're having difficulty. We're having difficulty hearing you. Try again. I don't know if anybody can help us to unmute Christelle so that we can hear. Christelle? No. Still not hearing you. I'm sorry. We'll try again. Any other thoughts? We had a comment from Edward, our colleague Edward, saying that people and persons who push for accountability are normally victimized or punished, and that we need a reward system for accountable champions. That I wonder if that is an experience that resonates with others in the group. Okay, Christelle, try again. Still not working. Sorry about that. One of the things that was raised in the mapping exercise, and even in the Heaven and Health theory, is the voice of people and the role of civil society. And it's been acknowledged that it isn't as strong as it could be or should be to really make accountability mechanisms dynamic, or to make this accountability culture dynamic. And I know that ACS is also working in Burkina Faso on this precisely. And Burkina Faso does have a particularly active civil society. I wonder if I could ask for Simon to maybe talk to us a little bit about, and I see we also have Joël and Orokia and Yamba from Burkina Faso. Would be interested in getting some of your feedback about how civil society is engaging in strengthening accountability for UHC in Burkina. Simon, est-ce que tu veux commencer? Je ne sais pas si tu as suivi ma question.
Oui, allô?
Oui, vas-y.
D'accord. Bon, en fait, pour résumer assez vite, bon, heureusement, on a effectivement la chance d'avoir une société civile assez active ici sur plusieurs niveaux en matière de redevabilité. Nous avons au niveau du Burkina des structures qui s'occupent beaucoup plus de l'analyse de la gouvernance des systèmes, qui essaient de voir comment est-ce que les systèmes sont organisés de manière à pouvoir être transparents et inclusifs. Et nous avons également d'autres structures qui travaillent beaucoup plus sur le suivi des ressources, la gestion des ressources, pour voir comment est-ce que effectivement cette gestion est transparente et orientée vers vraiment l'efficience. Et enfin, nous avons des structures qui font, dans laquelle s'identifie beaucoup plus le RAM, qui fait un peu beaucoup plus le suivi de l'accès de la disponibilité de l'accès aux services. Donc, ça fait 3 niveaux, effectivement, d'implication pour nous en termes de redevabilité. Et nous avons eu à un certain moment l'idée au lieu que chacun intervienne dans ces différents niveaux à part entière, nous avons eu l'idée de mettre tout le monde dans une plateforme qui s'appelle la plateforme démocratie sanitaire et implication citoyenne, qui fait ces 3 niveaux de suivi. Et c'est avec cette plateforme que nous essayons, comme Alison avait déjà dit, de créer ce mouvement social-là pour pousser un peu les avancées en matière de CSU. Voilà un peu déjà, pour ne pas être long, ce que je peux résumer. Et s'il y a des éléments en plus, je pourrais mieux étayer.
Merci, Simon.
Maintenant, mais rapidement aussi par rapport au dernier truc dont j'ai parlé, par rapport aux références en matière de CSU dont j'ai parlé, je l'ai évoqué parce que récemment, en faisant une étude sur le goulot d'étranglement dans la collaboration justement avec ACS, nous avons vu effectivement quand même qu'il y a des potentialités que nous pouvons exploiter pour effectivement faire des critères d'évaluation de la CSU. Nous avons donné des orientations à ces consultants pour qu'ils creusent davantage. Il y a des références qu'on peut trouver en matière de financement parce qu'on doit savoir qu'est-ce qu'il faut comme financement dans un pays pour atteindre la CSU. Et quand on va nous donner des informations en matière de finances, il faut qu'on voit est-ce qu'on va vraiment vers ce besoin. Il y a des besoins en termes de couverture, en termes de formation sanitaire. Il y a des références internationales qui existent. Quand on l'applique au pays, on doit pouvoir se dire combien est-ce qu'il nous faut de formation sanitaire pour pouvoir aller vers la CSU. Donc, il y a un certain nombre d'éléments comme ça. Je pense qu'il faut qu'on les prenne, on les mette ensemble et on les contextualise dans les pays. Et nous allons pouvoir nous créer des cadres de référence en matière de CSU. Et c'est par rapport à ces cadres de référence que nous pouvons demander des comptes à nos décideurs. Et quand ils vont nous donner leurs résultats, on va leur dire, ah, voilà, est-ce qu'on avance vraiment vers la CSU? On est à 2/3, on est à la moitié, ou bien on est aux 3/4. Mais si on n'a pas ces références pour les interpeller, ils vont nous donner des chiffres et on ne sait même pas comment les utiliser. Ils vont trouver les moyens pour s'encenser, pour se rendre glorieux avec ça. Et nous n'avons pas les moyens pour leur dire non, arrêtez ce que vous avez fait. Ce n'est pas encore grand-chose, il faut que vous fassiez encore plus. Donc, voilà un peu pourquoi est-ce que j'avais posé un peu cette question.
Très pertinente, oui. Christelle, I think you may have sorted your microphone issue. Would you like to come in before there's also some comments related to Edward's intervention. Christelle, but you get priority. Okay, I'm so sorry, but we're just not hearing you. Caroline Simumba, you put a comment in the chat. I'm going to ask you to just unmute and say it because I think that someone else also wants to come in on this. So would you mind sharing your reflection there? You should be unmuted now.
Alison, was that me?
Yes.
I'm sorry because my internet is so choppy. I actually dropped off at some point. Yes. So there's been a lot on SABC and ENCA, which are South African news channels, around corruption and accountability, and strengthening the health system, especially during the time of COVID, where we've seen a lot of misappropriation of the funds and the donations that have come in from both, private sector, public sector. And the real lesson learned is that, unfortunately, in our part of Africa, I can speak very strongly about that, there are still consequences to be paid for, wanting to hold, especially the public sector, accountable. And so the particular circumstances that were presented in this program had to do with, something that's totally unrelated to us, South African Airways, but also had to do with the fact that once someone blew the whistle on the misappropriation of COVID funds, PPEs were finding themselves dumped by a roadside just because people did not want to be held accountable for what they'd done. One man, someone in the Gauteng province, had been paid about 19 million rands, immediately went and, procured 5 very expensive vehicles, did not supply anything. So I think in the current, we're seeing a lot of the indicators of how challenging it is to be within civil society, within public sector, even worse, trying to hold the system accountable. That's my comment.
Mm-hmm. Shiknan, did you want to come in on this point?
Yes, sure. No, that is a really overwhelming finding for us. So I think it's really critical to be careful that the culture of accountability doesn't turn out to a culture of fear, like Caroline articulated earlier. Because even fear can inhibit actors' imagination, their creativity, their resourcefulness, etc. And don't forget that the purpose of accountability is really to help actors to increase, like I mentioned, the individual, collective, and systemic performance. And this is where we need, really a refreshed perspective on accountability. It shouldn't be a punishment tools. It should really empower actors to enhance their performance. And on that note, rewarding is really an important aspect. It's about both. It's not just negative consequences, but we should also celebrate those who are doing well, those who are doing a good job, so that transparency is not in certain setting like a big deal. No, it's not. It is really to help you, like I mentioned again, increase your performance. That is a big challenge. I think I see on accountability right now. We all, as actors, should mobilize and bring that complementary angle also. I stop here.
Thanks, Chikna. I would love to ask Rodriguez de la République démocratique du Congo to take part here. Please go ahead, Rodriguez.
Oui, merci, bonjour. Je vais parler en français.
Allez-y.
Oui, alors, bon, moi, je voudrais, donc je vous parle de Goma, c'est à l'est de la République démocratique du Congo, tout près du Rwanda. Et je voudrais savoir à quel niveau les secteurs privés, les hôpitaux privés, les cliniques privées interviennent dans la redevabilité. Hein? On n'a pas de la redevabilité politique, financière et de performance. À quel niveau les secteurs privés, et là je parle plus des hôpitaux privés, les cliniques privées, les autres, parce qu'ils font partie du système
Ok, donc ça coupe un tout petit peu, mais je pense qu'on a compris l'essence de ta question. Christelle, do you want to?
Yeah.
I'm hoping. Yay, we can hear you.
You hear me?
Please, yes.
So
your choice.
Go
Yes,
ahead.
sorry about that. But do you have? Would you like to contribute on Rodriguez's question?
Yeah, I can contribute on his question. Perhaps I can go in French and you have the translation.
Yes, it's fine. I think that's fine.
Ok, great. Vous avez vu au niveau du framework qu'on a trois types d'acteurs. Et il y a un type qui sont les prestataires. Et au niveau des prestataires, on a dit que les prestataires peuvent être à la fois du secteur public ou du secteur privé. Et donc, c'est à ce niveau que se retrouvent les hôpitaux privés par rapport à la redevabilité. Quand je prends par exemple l'exemple d'un mécanisme de redevabilité qui est l'accréditation, dans un pays comme la Zambie où c'est une politique qui est pratiquement mise à l'échelle, la redevabilité, il y a des hôpitaux publics qui également sont accrédités, auquel l'État applique ce mécanisme de redevabilité. Quand je donne un autre exemple, qui sont par exemple les audits de décès, qui est aussi un mécanisme de redevabilité, ils sont également appliqués au niveau de cette redevabilité. Ou quand on prend un cas plus grand de la qualité des soins, par exemple, les policy makers enfin, il y a eu la redevabilité de performance, c'est-à-dire les policy makers s'assurent que ces prestataires des hôpitaux privés offrent les soins de qualité sur lesquels ils se sont entendus en leur donnant, par exemple, l'autorisation d'ouvrir ces hôpitaux privés. Donc, j'espère que j'ai répondu à votre question.
Merci beaucoup, j'ai compris. Merci beaucoup.
Super. In terms of private sector and the engagement in accountability mechanisms, I would like to see if in Botswana you have any information you'd like to share with Rodriguez, Matsai, or Jane.
Yeah. Jane, do you want to talk about the role or the involvement of private sector? Jane, I don't think she's hearing, but we do have structures which are sometimes high-level structures at which private sector is given an opportunity to sit at the table. And the participation of the private sector is both at a strategic level, which is like maybe the heads of agencies, where they will then be in meetings with the health policy makers and very senior accounting officers of the Ministry of Health. And these meetings generally provide an opportunity for the health sector to share the status of health in the country and to talk about the direction that the country is moving towards and the priority strategies that might have been identified. And this provides an opportunity for development partners and the private sector to also maybe indicate or make observations around how maybe improvements can be made and also make suggestions as to how the private sector can contribute. And the private sector's participation is quite significant, especially when it comes to the role of the medical aid schemes. Medical aid schemes have really presented themselves for assisting the Ministry of Health, look at maybe funding mechanisms for health and look at how to structure the health system such that the public sector can probably or maybe claim from private sectors, from the private medical aid schemes.
Thanks, Matsai. Jane, would you like to add anything there?
Yeah, I just wanted to add to the fact that we also see strong participation of the private sector in the health financing technical working group, where indicators around financial protection are normally tracked. We also see the other technical working groups such as the expenditure tracking, which is one of the instruments that provide information around how the country is performing against the financial protection indicator. So we have a very strong health financing technical working group and with very good representation of the private sector. And all the decisions that are actually made at the technical working group level are passed on to the steering committees, which is a high-level government and private sector and development partners platform where all those discussions that were made and decisions or recommendations that were done by the health financing technical group are approved. So in Botswana, the private sector has a very significant role in terms of monitoring and even contributing to specific indicators that communicate to UHC. Over.
Thanks, Jane. I have been putting a couple of provoking questions in the chat because we really are quite anxious to get feedback from you as well. That's definitely one of our objectives. As I let you take a look at that, I also just want to relay Saini's question. How does culture play into these tools and approaches? Regardless of how comprehensive and sophisticated an accountability approach is, it might not work if it's not aligned with the country's culture. For example, Christelle says something about death audits, but that would not be applicable in many African cultures since the bodies of the dead are sacred. Sheikh Nada alluded to this point earlier when talking about Benin and said that it is not in their culture to tell on others. Therefore, how are we integrating the cultural with the technical? I think that's a very excellent question. Welcome any thoughts from panelists or participants on that important point. And we have yes, please jump in, whoever's unmuted. We have about 8 minutes left, and we will probably try to close the discussion portion here in about 5 minutes to just let us wrap up quickly. We also will be posting a link in the chat for a post learning exchange survey, another very quick one. And we would very much appreciate you filling it in. We are really trying to get a handle on how we're able to really exchange meaningfully with people. So I encourage you to check that link out and fill it in. I think there's a hand up. Where is it? I saw a hand quickly go up and quickly go back down.
It was me.
Okay, go ahead, please.
No, I wanted to address Seni's question. I think it's not impossible. Remember that in Botswana, for example, they engage with local authorities that are really well-respected, people, well-known in their community. And it has been found relevant and efficient to go through them and to ensure that people are contributing to the health issue resolution. And I think this is where we need really more creativity, more imagination, and it's possible because it's in our ecosystem, in our local setting. Everywhere we have social levers that function, because accountability is also about social interaction, right? So if you go in a country like Mali, where we have a griot, we all know that griots are really the social actors who can connect the dots, even in case of conflict. And if you want to be really efficient at that, don't forget to pass through them. And I believe that this social component is really critical. And I would say that even in every single country in the world, it's really possible to identify these social levers and to build on that to enhance accountability as well.
Thanks, Shikna. Do any of the other panelists have thoughts on how to ensure cultural appropriateness?
Alison?
Yes, Christelle.
Yeah, Seni raised, I think, very relevant points in the chat about accountability mechanisms such as the death audit that could not be culturally accepted, for example, in some country as a dead body are sacred somewhere. I think in Benin, for example, it is an accountability mechanism that is implemented since 2013, but now we are observing that there are some key aspects of this implementation that are not culturally accepted. For example, the name we give to this mechanism, we call it in Benin audit, and audit think about it is punishment at the end. They think it is like a financial audit, so directly they think about it. Secondly, at the end of the audit, if the result is a provider who is responsible, for example, of the death of the person, culturally it's difficult for people to accept that they are the responsible of the death of a woman, that all the days they will see the children of this woman, or they will also see the husband of this woman. So culturally it's difficult, and some parents also don't accept to discuss about the dead case, to give information to implement this accountability mechanism. So it's really important for any accountability mechanism that we want to implement in any context to take into account the culture, the cultural context of this country before designing, in the design and also in the implementation. Thank you.
Thank you, Christelle. Okay. So I just wanted to make a few housekeeping points, and then I'm going to ask George if he can close our session. As I said at the beginning of the discussion, and Shekhna mentioned at the beginning of the exchange, this is work that's in progress on ACS, and so we are really hungry for interaction and feedback and engagement. So we would very much welcome direct emails or comments in the chat box, or any contact with us with your thoughts as you've had some time to digest this conversation and the materials that we shared with you. We will share also this presentation with the group, and we will be coming out with products or documents about this work that will, some of them be probably published in peer review, but we will also be disseminating as project documents. You can always check our website, our web page, and maybe Katie or Amelia, I could ask you to type that into the chat. And so we will keep you informed about those as they come, as they are finalized. But we really, really would love to hear feedback on the Heaven and Hell framework, on the applicability of a mapping exercise like the one that we explained in another setting in a country that you might be supporting. So I want to turn over to George for some closing remarks, and thank you for my part participation. George, over to you.
Sure, thank you. Thank you so much, Alison, for that very exciting session. And I'm sure all of us would love to continue engaging. This is really, really good, but certainly we're out of time, unfortunately. And but I hope that we've not only learned something new from the 1.5 hours that we've been together, all the way from the cultural perspectives and challenges, engaging private sector, having a reference point, very, very exciting discussion here. And I'm so happy because I could hear voices giving us examples from Southern Africa. South Africa is Botswana, of course, West Africa, but also DRC, Congo, and Kenya, which is really good. So today, the whole of Africa kind of was represented in this conversation. Mm-hmm. And I like what you've said, Alison, that yeah, we want to continue engaging, we want to continue engaging, we want to continue learning, we want to continue improving what we've done today. So point 2 is that I also hope, actually, that this has energized all of us to ramp up our efforts towards improving accountability for universal health coverage. I'm not sure this could have come at a better time, particularly now when we reflect on the pandemic that we are facing and the fact that we need to strengthen our systems for it to be able to be more responsive to the circumstances that we are in. So I want to thank all of you for your time and insights. Our speakers, of course, Christelle, Conrad, Mate, thank you so much for
thank you.
putting together that. We really appreciate. Clap, please. And of course, moderator Shekna and Alison for leading these sessions really wonderfully. So thank you for that. I want to repeat what you said, Alison, that we also want to be accountable to these participants. And therefore, I want to repeat that we posted the link for a survey. We want to see how we can improve the next engagement that we have with you as much as possible in terms of how we are effective and how we align with what you'd like to discuss. So please take a few minutes after we are done to click on that and respond to us. We really appreciate it. But in addition to that, we'll also share the link to all of us so that we can respond. And therefore, again, thank you all of you for your participation, for your time. Merci beaucoup, and we look forward to engaging again soon. And a very good afternoon. Thank you.
Merci à tous. Merci beaucoup. Thank you.
Thank you.